Good morning. I am presenting Masquerades in Chronic Conjunctivitis, which is a retrospective review of clinical and histopathology reports. Conjunctivitis is an innocuous condition which is self-limiting, but when lasts for more than 3 weeks, it can be considered chronic. This is the old classification of chronic conjunctivitis as per Krashmer, and I am concentrating on cicatrizing conjunctivitis, which include ocular cicatricial pemphigoid, Stevens-Johnson syndrome, alkali burn, and trachoma. We aim to evaluate for hidden pathologies in cases of non-resolving chronic conjunctivitis. This is a retrospective case study, and we included patients who underwent conjunctival biopsy from January 2020 to August 2023 in a tertiary eye care center, and included a total of 19 cases. So, patients who presented with symptoms and signs of chronic conjunctivitis, which were progressing even with medications, were subjected to conjunctival biopsy, which included taking 2 samples, approximately 0.5 to 1 mm in size, from the conjunctiva where the disease is active, preferably the inferior bulbar conjunctiva, and subjected to histopathology and immunohistochemistry. Coming to the results, most of the patients were females, and most of our patients belong to the age group of 40 to 60. 4 of our patients had contributing factors. 2 of them were known case of Bishop's on immunosuppressants, and 2 patients were on AGM for a long time, raising the suspicion of AGM-induced OCP. And analyzing the histopathology reports, we had 1 patient who came positive for immunofluorescence for OCP, 9 came negative for immunofluorescence for OCP, 7 patients came positive for lichen planus, 1 patient came positive for SIN. This patient was later subjected to incision biopsy of the lid and came positive for meibomian gland carcinoma, and 1 patient had features of chronic inflammation. Coming to the management, most of the patients with OCP symptoms were controlled with topical immunosuppressants, whereas lichen planus patients required systemic immunosuppressants for improvement of symptoms. And the patient who presented with chronic inflammation was better with topical immunosuppressants. So, in addition to this old classification of cicatrizing conjunctivitis, we are now adding conjunctival lichen planus and ocular surface neoplasia. OCP is a chronic relapsing remitting bilateral conjunctivitis. It affects primarily conjunctiva and the mucosa, and it is a diagnosis of exclusion. When there is no history suggestive of Stevens-Johnson or chemical injury or trachoma, we can reach to OCP. It's an autoimmune type 2 hypersensitivity reaction. Association with HLA-DR4 and DQ7 is said, and common age group is 60 to 80, rarely younger than 30, and most commonly affects women. This is the staging of OCP. Stage 1 is subconjunctival scarring and fibrosis. Then it progresses to phoneal shortening. Stage 3 is when there is formation of symblefron. And finally, ankyloid blephron formation with keratinization of ocular surface and limbal stem cell deficiency. Direct immunofluorescence is the gold standard. We can see linear deposition of IgG, A, M, and complement 3 proteins along epithelial basement membrane zone. But the sensitivity is only 50%. So even if immunofluorescence is negative, we cannot exclude OCP. Hemtoxin and eosin will show inflammatory cell stain pattern. There will be a decrease in goblet cells and increase in mast cell population and pass positivity. Coming to the management, for mild staging of disease, preservative-free lubricants can be helpful in controlling the dry eye, scleral lens for controlling the irritation of the ocular surface, and topical cyclosporin and tacrolimus. But in moderate to severe disease, it will require dapsone, which is a drug of choice as per literature, or oral corticosteroids with immunosuppressants, and the most severe stage of the disease will require cyclophosphamide. Comparing with other studies, Christina et al. Study said they required only artificial tears for control of symptoms in 2 patients and oral steroids for 1 patient. Masquerades et al. Study said that they required oral steroids and oral immunosuppressants for better control of symptoms. Conjunctival lichen planus, isolated ocular LP is rare, and it's an inflammatory autoimmune condition with unknown etiology. It involves eyelids, conjunctiva, and cornea. It is clinically indistinguishable from other causes of cicatrizing conjunctivitis, and biopsy shows irregular coarse band of fibrin deposition over the basement membrane. In the management, topical steroids, systemic steroids, cyclosporin, retinoids, and cyclophosphamide, depending upon the severity of the disease. Pakravan et al. Study said that they required topical steroids and immunosuppressants for control of symptoms in their patients. And Brewer et al. Study said they required only topical immunosuppressants for control of the symptoms. We had this patient who was on oral azathioprine but showed increased conjunctival adhesion, and oral steroids were added, but still it progressed to sterile corneal ulcer, which resulted in melt and then perforated and self-sealed. Finally, tasography was done and oral immunosuppressants were stepped up. Another patient who was on 2 oral immunosuppressants developed perforated corneal ulcer, which was self-sealed. Oral immunosuppressants were stepped up, but still the patient presented with 2 episodes of recurrent ulcer, which subsided with topical antibiotics and steroids. And the patient is continuing oral immunosuppressants. Sebaceous gland carcinoma masquerades as benign inflammatory disease. It's a rare malignancy and it comprises less than 1% of all eyelid tumors. Our patient presented with blepharitis keratoconjunctivitis with stage 3 cicatrization. Conjunctival biopsy was done, which showed sin. Owing to the non-resolving blepharitis and lid margin thickening, incision biopsy of the lid was done, which showed poorly differentiated meibomian gland carcinoma with vegetoid spread and ocular surface squamous epithelial infiltration. The patient underwent partial thickness lid sparing excenteration. So, persistent signs not responding to medication should prompt biopsy. It will facilitate management of easily treatable lesions and early surgical excisions. Overpouring of steroids can be avoided in OCP, and early immunosuppressants can be initiated in lichen planus, which can prevent further stages of cicatrization. Thank you.
Nice compilation. Like lichen planus case, how did you come to a diagnosis?
Only with biopsy, sir. Otherwise, it is clinically it is same as OCP only.
What are you had any systemic this particular patient? Any systemic
No,
association?
sir, all lichen planus patients didn't have any systemic symptoms or associations.
Only eye.
Only eye. No, sir. But the oral immunosuppressants was started by rheumatologists, sir. So they had a systemic evaluation. They didn't.
They accepted the ophthalmologist diagnosis, and normally they don't accept.
Yes, sir, because it was a biopsy proven
Okay.
lichen planus.